Good morning, everyone. Welcome to today's Grand Rounds. My name is Adi Talati, and I'm one of the Grand Rounds directors, along with Drs. Alex Harris and Rebecca Muley. Today is our last Grand Rounds of the season. We'll return on September 4th with a special presentation by our new incoming chair, Dr. Josh Gordon, entitled aptly, Coming Home. So I hope you could all be there then. No departmental announcements except tomorrow, 1:30 to 3:30, there's an ice cream social in the multipurpose room upstairs, and the patio will hopefully be open as well if weather permits. We hope to see most of you there. Today, we close out our season with our June Jackson Christmas Grand Rounds, and who better to introduce Dr. June Jackson Christmas and her incredible legacy than our own Dr. Patrice Malone. Dr. Malone is the founder and director of the June Jackson Christmas Medical Student Program here. She is a newly appointed Associate Training Director for the Columbia Psychiatry Residency Program and Associate Director for the Division of Child and Adolescent Psychiatry. She serves as the current co-chair of the Diversity and Inclusion Alliance DIA committee that serves our clinical services in psychiatry for the Faculty Practice Organization and New York Presbyterian Hospital. She also co-founded the Psychiatry Residents Diversity Alliance, PRDA, at CIUMC, which serves to create community and promote career advancement among our multicultural trainees, as well as strengthen care for our diverse patient population. So I'd like to invite to the stage Dr. Malone, who will then introduce Dr. Jackson and lead to our speaker today.
Good morning, everyone. Thank you so much for joining us today for the Dr. June Jackson Christmas Medical Student Program Annual Grand Rounds. I started this program in 2016 with the aim of really exposing medical students from underrepresented backgrounds to the breadth of what a career in psychiatry has to offer in hopes that they too will become psychiatrists. I have to say, that I had a bit of a blast from the past this morning. So I'll share that with you all because it really was so heartwarming to me. One of our fellows from the original cohort is here from 2016. He shared with me that he is now an addictions fellow in our program. So I'll ask Rohit to stand up and we can give him a round of applause. So since the inception of the program, we've had about 60 participants in the program, including our current cohort. And those that have graduated from medical school, 75% of them have chosen psychiatry as their specialty. So I would call that a win for us in the program. Oh, thank you. We named the program after Dr. June Jackson Christmas because we really wanted to honor her trailblazing efforts in social justice and public psychiatry. Since the beginning of the program, she has always met with the students and shared with them over the course of 2 hours, usually, her history from babyhood to present day. Until last year when she wasn't feeling well and she ultimately passed in December. And I would love for her to share in her own words a bit about her history.
As a child in Cambridge, Christchurch, I came in second in the Girl Scout cookie selling, and the girl who came in first was also Black. So the prize was going to be 2 weeks at the Girl Scout camp and 1 week at the Girl Scout camp. And when we went to speak to the rector's wife, she said, "Oh, I'm afraid you won't be able to collect your prizes." We said, parents said it's fine, all that. No, they don't have Negroes stay at the Girl Scout camp in the next town over. I was about 11 or so at that point. She said, "No, I'm sorry, June, that's the lay of the land." I've never accepted that it's the lay of the land. I think you've got to change. If that's how the land lies, you've got to change it. In the 60s, we were part of a movement that was, or might have been local here, but it was a national movement. And it had many leaders, the activists, the SNCC folks, the SLC, and it was black and white. And it pushed for legislative change, pushed for voting, it pushed for the opportunities for people, and you knew something was going to go on, and it carried on. During that time, I worked with a number of the SNCC field workers who would come back from being in the battle, trying to enroll people in voting and register for voting, who were killed, some of their workmates, who were intimidated, who were mentally traumatized. And so when they would come back from the field, I would go, and not I alone, but others, and work with them in groups and support to help them deal with all of those stresses. Now, of course, it got me in trouble when I got to be a resident in Bellevue in the psychiatry and wanted to go to the next year under the Veterans Administration auspices. They had a record on me. Every march I ever walked in, every white boy I ever dated, literally, they had names of people. Every march in Boston in which the Communist Party, the Socialists, the Baptists, and even, as I pointed out in my rebuttal, the Catholic Church, too, marched against killing veterans. So that activity has its risks. I'm past president of the American Public Health Association, vice president of the American Psychiatric Association. I'm a founder of Harlem Rehabilitation Center and also a co-founder of the Urban Issues Group.
We are forever indebted to Dr. Christmas and hope that the JJC program will continue to honor her legacy. Thank you. So one of our PGY3s who recently joined the JJC team, Dr. Tofumi Oshodi, is going to introduce our speaker today. Dr. Oshodi is joining the JJC team as she plans to expand our offerings to undergraduate students.
I am so excited to be here. This feels so full circle for me. I was a JJC alum. I did this program twice, and I'm so grateful for Dr. Malone and the opportunity to introduce our speaker. It's an honor for me to introduce Dr. Debra Furr-Holden. Dr. Debra Furr-Holden is a professor of epidemiology and the former dean of the New York University School of Global Public Health. She's an expert in health disparities and policy-level interventions to promote health equity. Her research foci include drug and alcohol dependence, epidemiology, psychiatric epidemiology, community violence prevention, and prevention science. Prior to her tenure at NYU, she was a C.S. Mott Endowed Professor of Public Health and Associate Dean for Public Health Integration at Michigan State University, where she also directed the NIH-funded Flint Center for Health Equity Solutions in the College of Human Medicine. Previously, Dr. Furr-Holden was a professor in the Johns Hopkins Bloomberg School of Public Health. Dean Furr-Holden is a widely published scholar whose writings include more than 150 peer-reviewed papers in high-impact journals. She is the recipient of numerous awards and honors, including the White House Presidential Early Career Award for Scientists and Engineers. In 2023, she was elected to the National Academy of Medicine. She received her BA from Johns Hopkins University's Krieger School of Arts and Sciences and her PhD from Hopkins School of Hygiene and Public Health, now called the Bloomberg School of Public Health. Please help me welcome Dr. Furr-Holden.
Thank you. I was hoping that bio, because it had the years, I was like, oh, please don't say the years I graduated. When people do that, I start doing the math to back calculate people's ages. So anyway, thank you for having me. I'm really excited. It feels like a real honor to be able to speak in a space that was set up by Dr. Jackson. So thank you for inviting me. I want to recognize the fellows. So could the fellows please just stand? I always tell people I'm a program kid. I did every program that was available. And I'm literally a program adult and a program dean and a program leader. I did, early training programs. We had one at Hopkins. I've gone to dean school. I'm in president school now. Like, there's real value in this. So, tipping my hat to you all for making the good choice to take this opportunity. Just quick disclosures. I have no relevant financial relationships to disclose, nor any other conflict of interest. I don't think I have to read these out, but there are learning objectives laid out for this session, specifically for you to get some insight around historical and current behavioral health disparities and a little bit of understanding around the root causes of those things. I'm going to talk about some evidence-based and promising practices to reduce systemic inequities in behavioral health and behavioral health care. And then I'm going to give you a couple of clinical examples. And I'm not a physician. I always say I'm not that kind of doctor. I have a PhD from Johns Hopkins. So I would never tell a clinician how to do their job. But I will say I've had some of the most rewarding work I've done has been working in partnership with people in the clinical space. And I'll talk about some approaches that we've used successfully to prevent and reduce behavioral health disparities. And it is my hope that you will leave here and say, I need a good colleague who's an epidemiologist or kind of doing this disparities work, because I think the partnership is potentially unparalleled. All right. So, oh man, my animation doesn't work. Okay, it does. So I was like, oh no, because I feel like if everything goes up at once, you're reading the slides and not listening to me. And I want you to listen to me because you can have the slides at the end of this, and you have my permission to use them. I just want to make sure we're all in the same conversation. So people will oftentimes use disparities and inequities interchangeably, and they are not actually the same thing. Disparities, a simple synonym for disparities are differences, right? So, apple versus orange. That tends to be person-centered. You will hear oftentimes people talk about upstream, downstream, and I'll tell you what I mean by that in a second. And I'm using this example around race because it's just at the forefront of a lot of what we are dealing with in our society and in health and in healthcare like that. And when we talk about disparities, we'd be talking about racial differences, right? Like Blacks are higher on this, or women are higher on that, or left-handed people have more of that, like that, right? Different from inequities. So a synonym for inequities or for equity would be like fairness, right? So it's not just the differences, it's what is giving rise or the cause of the differences. So you can think of inequities as unfairness. Instead of it operating at a person level, it tends to be more focused around systems and structures versus people. It tends to have its roots in things that are more upstream. And I'll again tell you what I mean by that. And that's where you would find racism. And people say this all the time and it burns me up. They say race is a social determinant of health. Race is not a social determinant of health. Racism is a social determinant of health, right? There's nothing inherent about your race that should impact your health. It's what your race then gives way to in your experience out in the world and in healthcare settings. Okay. Just foundational. Again, I only have like 2 more like this, and then we're going to jump into some real meat and some examples. Has anybody ever seen this before? Oh, then I don't have to go through it a lot. There's all kinds of different examples. I just want to give you a way to think about it that might be a little new. When I went to Flint, and I was in Flint, I went to Flint, I left Hopkins. I loved Hopkins. I did all of my training there. I loved Baltimore. I one time made the mistake of somebody said, oh, where are you from? And I said, oh, we're from DC. And my kids were like, you're from DC. We're from Baltimore. Like, they love Baltimore. I love Baltimore. I loved Hopkins. I also lived in Flint as an adolescent, and I went there at the height of the water crisis because they literally had not one epidemiologist in the county. So I went there, very, very rewarding work. The first time I put this up in Flint, I said, this is equality. Let's pretend out what's out on the field is everything that one would need for optimal health. And you can see the guys who've, got this bird's eye, opportunity for optimal health or view of the game. They came to the game differentially sort of prepared. There's that fence up. So you can see the tall guy, he doesn't need anything. He can actually see over that fence without those little boxes at the bottom. The guy in the middle, now he can see. And the short guy on the end, even with the box, he still doesn't have what he needs to see the game or have optimal health. That's an equality model. And I've seen this play out a lot. I've served in a few sort of practice roles. I was the director of prevention while also a professor at Hopkins for our behavioral health authority. Most exciting, rewarding work I've ever done in my life. And this is how they used to do it. The state used to say, well, we've got 24 jurisdictions in Maryland. We're going to cut the pie in 24 pieces and give everybody their fair share of the pie. But one could argue that's not really fair, right? If you know Maryland, I'm from Prince George's County. That's one of the biggest and also highest need counties versus a very small county like a Cecil County, which has 1/10 of the population and a fraction of the need. So there's nothing wrong with equality. It just often doesn't work when we're talking about how to allocate resources to solve problems. So then I had this side up, equity, right? It's more about fairness, people getting what they need. And again, you have the same 3 boxes, pretend that's the resources that we have to solve our problems, but now they're distributed in a way that feels more fair, right? Because the goal was to use the resources so that everybody could access the game. And now everybody could access the game. I put this slide up in Flint and people, and again, I'm just trying to frame things for people and get us all in the same conversation. And people got up in arms. Somebody raised their hand. I said, we're gonna do questions. And no, I want to have a question. How'd that little guy get up there? Did the tall one have to pick him up? Because that's undignified. People should be able to maintain their dignity at the game. And I was like, well, yep. I mean, it's just an interesting way, right? Because we've sort of said like equity is the new thing, right? People talk about it all the time. They talk about social determinants of health. People also are talking about the political determinants of health. You talk about equity, but for a lot of people, when they see stuff like this, they're like, no, it doesn't resonate with me. And when they map it onto their own experience in their own communities and their own healthcare clinics and their own centers and like that, they're like, I don't want your handout. I want access and opportunity without needing a handout. And so, and there's many different examples and ways to think about it. Again, I just wanted to get you into the world of thinking about it the way I think about it, so the rest of the stuff I'm going to say makes sense. If you think about the social and political determinants of health, let's say the fence is needed to stop balls from coming over there or whatever, but you can actually change systems and structures that then create fair play and fair opportunity. And if you notice in this example, we don't need the resources. If you have to have the fence, well, a fence that everyone can see through, no matter how tall they are, solves that problem. And now those 3 boxes can be used for something else. So I just want you to sort of think about it that way. I'm going to give you a couple of examples, and then I'm going to ask you to think about in your own work where you might see the opportunity for systems and structure level change, because that's where I really think we're going to see our biggest and most sustainable efforts. Okay. I'm not going to spend a lot of time on this. Race is a social construct. Racism is systemic subordination by a majority group. We're going to put a pin in that, but I'm going to use a few examples that are anchored around race. And I just want to make sure people get the difference between race and racism. And then lastly, this distinction of upstream and downstream. This actually comes out of geology. Think of it this way. They say the stuff rolls downhill. So when I talk about upstream, I'm talking about the causes of the causes. What we see downstream are the disparities, the difference. The question is what is the cause of those differences? All right. Oh, this is a graphic that I really, really love. And some of my colleagues have argued with me about it because I put these sort of social and political determinants somewhere between upstream and midstream. But again, what we see down here, this is community, right? You have individuals. This is where all of our treatment is. This is where all of our healthcare costs, et cetera. And this is where we see disparities. But as you move further upstream, you'll see we've got norms, laws, enforcement or lack of enforcement of those laws, how resources get allocated, programs. And then as you go much further upstream, you've got systems, federal laws and policies, funding priorities. There's nothing worse than being a researcher who has something in your heart and soul that you really know needs to happen in the world and you want to do, and there's no agency interested in funding that type of work. And I can tell you, most agencies haven't been funding the type of research that I've been interested in and been doing. I've always had to frame it and couch it some other kind of way. That is now changing, but that's what it was like 20, 30 years ago when I started. All right, I'm gonna give you a few examples from the field. I gave you all this article, but I actually wanted to unpack it just a little bit. And I'm going to specifically highlight this example around opioid overdose death. Again, shared the article with you. So what do we all already know, and what does the science and data tell us about opioid overdose death? So one, we know that it's preventable and opioid addiction is treatable. People can and do recover. Second thing, we know that social and political determinants are key drivers of not just opioid overdose death, but the disparities that we see in opioid overdose death, right? Again, because we know how to intervene, prevent, treat, and support recovery for people. So there are factors outside of the individual that are driving some of these differences. And oftentimes the level of solutions, i.e. the things that we are implementing, aren't necessarily a match for the level of the problem. So if you've got a community access problem, but all the programs are focused on individual behavior, you haven't really met the problem fully. So as some background, opioid overdose death has historically been substantially higher among whites compared to all other population. In 2017, the U.S. Department of Health and Human Services declared a national opioid epidemic. You know, COVID sort of trumped all of that, no pun intended, but it was like a big thing. And it got a lot of, not just attention, but a lot of resources. And this really, to me, well structured, evidence-based 5-point strategy was rolled out to take it on head on. This was something that was really great for me, being somebody who lived in Baltimore, which is a port city, and has been dealing with a heroin epidemic that way predated what we are calling now the current opioid epidemic. You know, people said, oh, it's racist because now that it's impacting middle-class white America, people care. And my thing is, I don't care what got the government to sound the alarm and to roll out these resources. I'm just happy that the time has come. So 2017, we got this DHHS declaration of an opioid epidemic. And then in the year that, and a lot of money rolled out. And the year that followed marked the first national decline in opioid overdose death in over 30 years. That decline, however, I got the data, it comes from the National Vital Statistics System. I disaggregated the data by race because I sort of went, this doesn't map on to what I'm seeing in communities where I'm working. It looks like it's getting worse for Black and brown people. So I got the data myself and I disaggregated it. And lo and behold, that decline was attributable solely to non-Hispanic whites, because non-Hispanic whites are the majority of the population. Basically, what they experience has the potential to dilute the whole entire picture. And so this is what it looked like sort of statistically. This is just a Black-white comparison. We have a follow-up. We also included Hispanics. And as you can see, the curve for whites is on the bottom. I'm sorry, the curve for African-Americans is on the bottom. It had historically been a very low, flat curve. And this is national. So this is like all of the US. And then in 2013, enter illegally manufactured fentanyl. And then you see this rapid acceleration in the African-American community. You also saw a uptick in whites. And then what happened in 2017 is all of that great work that was done and all that stuff that got rolled out, whites went down and African-Americans and Hispanics continued to increase. So we think about it like if you're in a race, you might start behind, but they're running way faster. So they're outpacing their white counterparts. And I can tell you now, these curves have actually crossed. This is an article. You all have a copy of it. And what we figured out then, and now we're picking up on, is opioid use and opioid overdose death at this point continued to disproportionately affect whites. The rate was a little bit higher. That has actually now changed. And why it changed? Again, think of the race analogy. They were running so much faster, they eventually caught up. And I always tell people, one of the things we do not want to do in the disparities work, the goal of solving health disparities is to make sure that everybody has like fair, equitable opportunity for health and longevity. The goal is not to have whites be sicker, because that has actually happened. And I have watched people claim a victory because the white population on a particular, outcome, something happened and they got sicker. That's not how we want to solve disparities, right? So what we see here is these strategies work, but something happened where the strategy wasn't experienced fairly and equitably by everybody. And the question is why? And so I talk about racialization of the opioid epidemic. And I'm going to give you 3 examples of what I know happened that I did a deep dive on in my community in Michigan. So one of the strategies was starting people on medicated assisted treatment in the emergency department. When we looked across a sample of hospitals in Michigan, what we figured out is in some places there was as much as a 15-fold difference in who got started on medication-assisted treatment in the emergency department. And the 2 strongest predictors were being white, male, and having private insurance. Now you can imagine those variables might also be proxies for some other things, right? If you have private insurance versus Medicaid, there's probably some socioeconomic variable at play there as well. You might have more resources, more wealth, et cetera. But a 15-fold difference by race. So we know this works, but it doesn't work if you don't do it for everyone the same. Narcan administration. There was a massive effort, and I said I was the director of prevention for the city of Baltimore for several years, and somehow opioid overdose prevention got put under my wheelhouse. And I kept explaining, no, I do a different kind of prevention. Think prevention like school-age kids. But they were like, yep, you're all we've got, so we need you to do that too. So I have a lot of experience in how to do this community-wide rollout of Narcan. When we looked in Michigan, what we found is there was a big difference in even how that got rolled out. So and don't get me wrong, in Michigan, opioid overdose death is disproportionately higher among whites. So it would make sense that you would see a higher rollout in those communities, but not at the degree to which we saw it. So some of the things that we know work to prevent people from dying from an overdose, again, we just didn't do a good job of getting it to all communities fairly and equitably. And then the last example I'll give is around recovery-oriented systems of care. I think you might have one of these articles as well. We started, and I did this work in Baltimore, and it was really awesome to be a part of getting it stood up in Michigan. Peer recovery support services and all the things that come with ROSC, whether it be housing, vocational training, all of those kinds of things. Well, when we looked in Michigan, we specifically honed in on the housing factor, because obviously housing is a big problem for people who are dealing with addiction and like that. The difference in the type of housing that people could get by race was astounding, and also gender. And here it became the opposite. In fact, it was white women who seemed to be the biggest beneficiary of all of the ROSC related services around housing. The rate for acceptance into these housing programs was below 13% for African Americans, and it was 89% for white women. So it's like you get this great program, you have this housing voucher, and then people won't accept it. So you are then forced to live where people will take the voucher, or even worse, not even be able to use the voucher and live somewhere that probably isn't going to be conducive for your long-term recovery. I'm just giving you these examples so you can see when we have these great things that we know work, but we aren't equity minded around them. We're not looking at the data. There's no enforcement or checks and balances to make sure that things are being fairly and equitably considered and rolled out. We get what we get. And so the nation pat themselves on the back. We had our first decline. And then, in fact, we find out not for everybody. I included this in here too. This is not my article, but they did a follow-up to that the following year. And in the HEAL study, which if any of you are researchers, you might be familiar with it. And so again, the trend continued to persist. One of the things that came out of that, and there's a whole new field that we're sort of opening up now, is when I went to then understand, I wanted to understand what type of opioid, right? Because remember, I came from Baltimore. It was a heroin town. I know now we've got people who are, polydrug users and they're mixing and using multiple opioids and like that. I said, I want to know what type of opioid people are using and what type of opioid by race, by gender, by geography are driving opioid overdose death. So when I went and looked at the data, I think it's the T40.6 category, which is unspecified opioid narcotic. When you go back in the data, we looked at this over about a 20-year period, and this is all in this publication. I have all of these at the back with the QR code so you can easily access the article as well, if you'd like to. For African Americans, if you go back 20 years, the missing data or the unspecification of the type of opioid in that sort of period from like 10 to 20 years ago, the lowest it was about 20%. On the worst year, I think it was 67%. So let me tell you what that means. And by contrast, the numbers were on the of unspecified opioid for whites was somewhere on the order of about 3 to 7%. So even in death, we controlled for everything. You can look in the article. Well, we said, well, maybe Blacks are more likely to be somewhere where there's a coroner versus a medical examiner. Maybe they're in lower resource places. Maybe there's more deaths. Like we looked and controlled for every possible variable because I didn't even want to accept this fact myself. Nothing explained away this difference. A little bit of the variance got explained, but only a very small amount. The original name of this article in AJPH just would not publish it with that preface. I said, even in death. That was the original preface on this article. So even in death, somebody sees a Black or brown body on the slab and doesn't do as good a job on the death record. And there was no getting away from that. So then I got really interested at where else is this happening? Because that data for people like me is important so we can make sure we are telling the story accurately and then building the case for the resources that we need. I couldn't even make the case that, Baltimore is a heroin town. And so what might be needed, when people started with heroin and now they're adding I couldn't even do that because the data for African Americans in Baltimore and in most places, there's just so much missing. The quality of the death record for African Americans is substantially worse than their white counterparts. So that has opened up a whole can of worms for us, and I've now defined this. Health data disparities as three things. One, the unacceptable and unnecessary omission of race and other demographic data from health and from public health data. And we actually saw this in COVID. I was in Michigan originally when the vaccine was a hot commodity and everybody wanted it. It was prioritized for frontline healthcare workers and people, I forget the age, maybe it was like over 70 or whatever the age was. And it was a federal mandate that you had to collect these 5 demographic variables on every person that got the vaccine because you had to prove you were in compliance with the rollout strategy. And it was race, it was age. Of course, people wanted to collect age because they wanted to prove we are giving it to, people who are in the first line of people who qualify. It had like an occupational code to make sure it was like frontline workers like that, or essential workers, gender, and it was like some geographic variable like zip code or something. In Michigan, the first 2.5 million doses of vaccine that came out, they had 10 out of 2.5 million doses, 10 were missing the age. 71% were missing race. So we couldn't even see and answer the question if there was any inequity in who was and was not getting the data. So this idea around, and you can Google it, I did a whole lot of press around it. There was a bunch of news articles around it. It's like mind-boggling. Like, how is that possible? And people would say things like, well, people are uncomfortable, reporting that, or uncomfortable collecting it. And I'm like, that is just not true. When I go to the doctor, I have to give them my full government name, social security, date of birth, exact mailing address, or they can't bill my insurance. And my doctor won't see me if I refuse to give all that information. People are used to providing basic information to access healthcare services. But again, people will point to things instead of dealing with the real issue, which is if we don't have the data, then we don't have to confront that we aren't doing a good job of making sure people are being treated fairly. So that's the first piece of it. The second piece of it is poorer quality data for certain populations. And I've looked now, and I have access to the Cerner Health Facts data through a partnership I have with Oklahoma State University. We're probably on our third round of submitting this R01. It keeps going to weird panels to look at all across the landscape of at least Cerner Health Facts, which is second to Epic. And so it's a massive amount of data. We've done some preliminary looks, and you can actually see that this health data disparities issue is not just a race one. Preliminarily, for people who are and underinsured, they also have poor quality data. Why might you think that would be the case? Well, providers, when you want to submit an insurance claim, missing data costs money, just so we're clear. Missing data costs money. So hospitals and administrators and all of that have some skin in the game, not because they care about, I think, this, but yeah, would it probably improve patient outcomes? Probably so, but it will also improve reimbursement. So people who are and underinsured, there's nobody to bill except for them. So, I mean, it's just, if you really think about it, these are the biases that well-meaning individuals bring to their daily work. Not bad people, really good people, people who are making the difference. And we'll talk about blind spots and bias, because I'm going to tell you what you sitting in your chair might be able to do if you want to sort of join the fight and not at least contribute unconsciously to the problem. People with disabilities, people who are deaf and hard of hearing, really, really bad. I mean, I just was like, when we actually got into it, I was like, none of this is like a super surprise, but I was really, I was a little disappointed. I'm like, wow, it doesn't these are all things that we could solve, but now we need to know them. So I'm working with the group. Like I said, we have this R1, and we also have a patent for an analysis package that will run analyses on your data and tell you information about patterns of missingness. It'll identify people, particular groups, time of day. It'll tell you information about your patient population. Because again, the goal is to put tools in the hands of providers to be able to identify and then solve some of these problems themselves. And then the last thing is a lack of contextual variables, things like the social determinants of health. So you're treating people in a vacuum, right? And my mom was a diabetic. I remember her going to this, nutritional class that they gave her. And then she came home and she was so proud. She said, I cooked my first diabetic meal. And I said, well, Mom, what is that? It was a piece of steak swimming in butter. It was, I call it broccoli mash. She had boiled the broccoli until, all the vitamins and nutrients were in the water or boiled off. And the broccoli was literally just like a mash. And then she had like a small little multi-grain roll that also had a big thing of butter on it. I said, I'm just curious what were you told and how does that translate into what you prepared? She said, well, they told me not to fry the steak, but to broil it. So instead of just frying it in the pan with a bunch of butter, she broiled it in the oven with a bunch of butter. They said broccoli is good for, this and that and that and that. And she doesn't even really like broccoli, but she's like, it's palatable if I just boil it a lot to make it like a mash. But she's in essence lost all of the, I'm thinking, this is crazy, but nobody bothered. And my mother was an amazing, brilliant woman. But her education stopped very early on in life. What she would have needed would have been very different from what was provided for her. I go back to when she lived in Flint, Michigan. Flint, Michigan is technically a food desert. I don't really like the word food desert. I prefer food swamp because there's lots of food around. It's just not the kind of health promoting, nutritious food. It's bad food. My mom used to buy her groceries at the Family Dollar in when she lived in Flint. Because in her words, that's the nearest grocery store. The Family Dollar. You guys know what Family Dollar is? It is not a grocery store. Flint, I just left Flint 2 years ago, just got its first full-line grocery store, and they haven't had one in over 20 years in the city of Flint, like about 2 months ago. Can you imagine living in a city where there's no grocery store and you buy your groceries at the Family Dollar? Imagine if we had tools that would give people that. I've watched, people and physicians give recommendations. Oh, you should exercise more. You should this, you should that. How would that change if you knew that person lived in a very violent, high crime neighborhood and there were no sidewalks? All of this data. So this is another patent I'm working on. This is all the cool stuff I'm doing on my research year. I'm on a research year, which started July 1. You will be able to put in someone's address, and you can put in their home address. You can put in their mom's address where they spend the weekend. You can put in their work address, and you can auto-populate a series of variables that should be helpful and informative for a provider who's then making recommendations to a patient. So for example, we've got all the pharmacy and the price data. So you'll know if your patient is in a community where they're price gouging at the pharmacies. We did a study, and sometimes a simple hypertension medication, which, people have to take that stuff every day, can have a 5 to 10-fold difference. And oftentimes it's most expensive in the poorer communities because they can get away with it because people have no choice but to get their prescriptions there. If you knew that, you might say, hey, this prescription is likely cheaper if you get it at work, where you work, versus getting it at home. Or even better, maybe you should be a part of our mail order prescription program where the prices are more normalized, whatever. I don't know. You guys, I'm not that kind of doctor, but my thing is data. So giving you the kind of data that you would need to best support and meet your patients where they are. So this is the world of sort of health data disparities, and I think a part of where we should be going with solutions. People ask all the time, how do you track disparities? And I'm like, just look. So I'm not going to spend a lot of time on this. The first thing is you got to collect the data. And simple. You just disaggregate the data. Like this isn't, and I'm an epidemiologist. We are like first cousins to the biostatisticians. And people love starting off with the propensity score matching high-end, multi-level, generalized growth. Mitch, I'm like, could you just do a 2x2 first? Could we just do like a frequency distribution? Could we just disaggregate the data? These are very simple but potent tools that allow you to unmask and see things that otherwise you might not see. When I was in graduate school, we used to treat race, gender, income, education like noise, and we just controlled for it. It was just a control variable. And we now know that that's not the proper way to do that work. We would say the relationship between A and B persists even after controlling for all of the things that we know are really important to look at the data, disaggregate it versus treating them like noise. So you don't control or adjust away the disparity, and you let the data speak for itself. I have a lot of colleagues who I think are very guilty of being agenda-driven. And as a scientist, we are to be hypothesis-driven, not agenda-driven. It is not our jobs to cast our statistical fishing rod in the data and keep trying until we pull back a finding that we like. And I will be honest, people do it all the time. That's why it's important that we really honor this peer review process, that if you are tapped to do a peer review of an article or something like that, that we do the best job we can at stopping agenda-driven science from making it out into the world. Okay, all right. We're gonna talk about some solutions. I'm gonna fast forward because you want me to stop at 12 or 12:10? 12:10, okay, I got 15 more minutes. Is this resonating with people? Yeah, okay, good, okay. We have to grapple with the tough conversations and have an authentic reckoning with our past. So I'm gonna give you some examples now that are a little bit outside of this, because I think, again, I'm trying to inspire you to maybe think about some things differently, or maybe see some things in your own space, in your own practice, in your own, like that. So I was in Michigan when this happened, and this did pass. So Michigan outlawed any discussion of critical race theory in schools. And the legislator who led that said, we don't need to make young white kids feel guilty about things that they didn't do. Their ancestors did that. And, you know, we fought back and said, oh, it's more than that. It's like, it's, you know, people understanding how their world works. And, you know, Black children still have to live under the weight, and Hispanic children and all that of racism. So, like, you know, we just want to be able to teach history through a lens where people can understand how race and racism and white supremacy and white privilege and all of these things have played out and now shape our current landscape. In Michigan, by and large, it was a majority vote in both houses have banned critical race theory. So we will not be grappling with those tough conversations. We will not be having those. And what is likely is we will be reproducing people who think the world is fair because they can point to a story of my grandparents came here from wherever with nothing but $5 and a dream and like that. I mean, some of the things that I've heard there and some of the things that people said during this process and all the testimony. And I thought, man, I wish that's all I had was one generation and grandparents that came here with $5 and a dream. Because I have intergenerational trauma and narrative that has been passed down to me that is much heavier than one generation of somebody who came here for opportunity versus being born in a culture or in an environment where you're taught that you have to overcome. You were born behind. So grappling with the tough conversations. And I like to, I'm not going to go into a lot of depth about this, but poverty is not an equal opportunity experience. The incidence and persistence of poverty is way worse for Blacks than it is for whites. And that has remained the same over time. This particular study went from 74 to 14. And as you can see, in 40 years, they made almost no impact in the percent of African Americans living in poverty. In 1974, it was just around 40%. And in 2014, it was about 37%. So it's just persistent. And then there's intergenerational poverty. And what this shows is if you were Black and lived in poverty at least 1 year in your childhood, the chances of you living in poverty are almost the same as an adult. So if you ever lived in poverty 1 year as a Black child, you are likely going to live in poverty as an adult. Whereas if you were white, you got about a 50% chance of making it out of poverty. So if you lived in poverty for 1 year as a child, about 50% of those people are going to live in poverty as an adult. But for African Americans, you can see it's 41 and 43%. It's almost the equivalent percentage. So there's something about this experience. And again, I'm using these examples because they're just relevant and salient. But if you think broadly, this also maps on to ableism, people with disability. It oftentimes will map on for sexual and gender minorities. We just are growing that data in those areas. So I'm using the examples that I have sort of right at my hand that are telling the story, but you can almost think like there is this underlying sort of ism that is at play. And I imagine over time, we're going to see more work like this in some of those other places. All right, so again, some of the solutions. We got to plug up the leaky pipeline. Are people familiar with the 17-year odyssey? So there's a whole new emerging world called dissemination and implementation science. Some people have been at it for a couple decades. I feel like it is one of these other things that has really grown in popularity. I call that the science of up and out. So we know what works. How do you take what you know works and get it scaled up and out into communities, into settings without losing its effectiveness? That is what the science of dissemination and implementation science is all about. But the gap that we have right now is, on average, it takes about 17 years for 14% of research to ever be translated to anything in the real world. So 17 years for 14%. So the other 86% dies on a vine, in a journal, on your laptop, somewhere else. And then it takes 17 years for that. Can you imagine half of the things that we are now translating 17 years later are probably not even relevant? We've built bigger and better mousetraps. So this idea that there's this leaky pipeline, and then how many people here do research or are interested in research? Yeah, there's nothing worse than having your brilliant idea and nobody willing to fund it, right? So you've got priorities for research. Think back to that other upstream. You know, this is a conversation that I keep having unrelenting with NIH. You all are determining what research is being done. I was a standing study section reviewer. I've been on 3 or 4 different committees as a standing member and probably done 25 ad hoc reviews. NIH loves an RCT. It is like the shiny nickel, the golden ticket of the NIH, like a randomized clinical trial, randomized control trial. But at what point, and if you go into NIH Reporter, and sometimes I do this before I give a talk, I didn't do it today, and you put in the word trial, you're going to get a number. Then put in the word, just in the keyword search. So if it's anywhere in the title, the abstract, like that, put in the word implementation. Put in the word trial, and you're going to get some number. And then you put in the word trial, and you're going to get a number that's going to be about 20% of that other number. They are much more likely to fund trials, whether they be clinical trials, controlled trials, like that. They just love a good experimental design. But at what point do we take all of that knowledge and then translate it and say, okay, we know this works. I worked in public, mental health. We've done all of these school-based interventions. At what point do we get these interventions baked into the school system? Since we know they work, we've got a cohort that we've been following for 30 years. We picked them up in first grade. We are now following up their children. We know what works. We know how it works, but people aren't able, 1, to be trained, and then 2, to be funded to figure out how to get that stuff baked in. So many, many places on the leaky pipeline. One of them that I want to talk about, since we're at an academic center, and I came out of Hopkins, and Columbia's, very much in that vein of the Hopkins. We've got these really perverse incentives that promote hyper competition, and I think sometimes undermine really people's, sort of true calling and what really brought them to this work in the first place. Again, I have this article with the QR code at the end. I would recommend this as a read for anybody who's interested in sort of like this, classic academic track, whether it be academic medicine, whether you be a researcher, like that. And this is stuff that we can actually do something about, right? So I was in Flint. I was in Baltimore. I worked for 7 years on legislation to impact zoning in Baltimore, which hadn't happened in 40 years. The city went from about 1.3 million to about 660,000 people over that time period. So it shrunk by about half. And what people didn't take is the liquor stores or their homes. So we had really bad housing stock, lots of vacant housing, which gives way to shooting galleries and all kinds of things like that. We also had oversaturation of liquor stores, because the number of liquor stores that you would have for 1.3 million people is not the same for 660,000 people. I worked on that for 7 years. I had somebody throw a brick through my window. I was on a radio show and a guy, a liquor store owner, lunged across the table. He owned a place called the Snop Shop, which is now shut down. And he was fighting because we did legislation to get them out of existence, the ones who were not zoned properly and other things. I mean, I put my whole heart and soul into this. I think I got about 4 or 5 papers out of it, but it was the single largest, most impactful thing to reduce violence in Baltimore was getting rid of these non-conforming liquor stores. And don't you know, when I went up for promotion, and at Hopkins, they only tenure at the full professor level. You don't get tenure at associate, and it doesn't mean anything. The tenure means they'll keep your name on the, on the marquee. But if you don't have money, it does not come with salary. It doesn't come with any of that. And people were like, well, you don't really have enough publications and you're an epidemiologist and, some of your peers. And I was like, I led the single largest thing to reduce violence. We had our first decrease in violence the year following this that we've had in 30 years. Baltimore averages about a murder a day. And we cut that by about 40%. Multiple things, but this was like the moneymaker. And I was just like, this is crazy. So you know what I had to do? I just go find some data, some national data. And I wrote a couple brief reports and it was terrible. I was like, this isn't me. I'm not like a get paper person. But if it's the game, and I tell all academics, it's the coin of the realm. Publications are the coin of the realm. It's currency. You know what you use that currency to buy? Grants. And then that's new money that allows you to produce more publications. It's a weird thing that sort of feeds on itself. So we have to figure out, what do we think really matters? How do you give somebody credit for impact if all we're doing is counting? We're not even reading, we're just counting. How many publications do they have? And what's the impact factor of the places where they are? And how many grants have they gotten? Okay, include and honor the valued voice of community. I'm not going to go into a lot of depth here. I'll just say there's a lot of really great work. We have a really great model that we've laid out on how to effectively, authentically engage community. We developed this continuum. Again, I'm not going to go into that. I will say I'm a hopeless romantic. I love this show, Married at First Sight. It's people who just are in love with being in love and they meet their partner at the altar. I would not recommend that for community engaged research. You want to do some work. It doesn't really work out on the show. I think only about 20% of them make it after 2 years. And it could be worse in community. And the one caveat I will say for anybody who is interested in the continuum, people always talk about CBPR. Most of what we do is not CBPR. Just community engagement, community involvement in research. Think about these. The most important things are the same contextual factors that serve any relationship, which is history, trust building, transparency, respect, and all of those things. It's no different than when you're engaging with community. And I say community, it could be a community of affected people. It could be community, the geography where you are. It could be community and affinity group like that. Okay. And I just put some examples of how we've done that. I think it's also important that we study more than just individual risk, that we also talk about resilience and do a better job of figuring out what's the secret sauce? What are the factors that have people and communities hold on and thrive even in the face of adversity? And we did this in Flint. We created a healthfulness index to try to help guide some of the work that we were doing there. Policy and action-oriented research. Again, these are examples. And, like I said, I worked a lot on this. All of my colleagues, so we had so many students, fellows, all the like involved. And we published, like I said, 4, 5, 6 papers on that. I'm going to skip through that. This is a really important one. You have to get it baked in. And the story I love to tell is the first time, I was at MSU at the time. I had my little graphic illustrator make this. I had my MSU green jacket on. First time I baked a cake with my daughter, Olivia. She was 6. She's now 22. And she wanted to bake a cake from scratch. And I'm like a box cake mom. So we got all the ingredients. We went to bake the cake. We mixed and everything. We put it in the oven. We have a wall oven. She's peeking through the wall oven, watching it bake up and I'm cleaning everything up. And then I realized the box of Domino's sugar is unopened. And I was like, oh man. And she's like, Mom, what's wrong? I said, oh, Libby, we forgot to put the sugar in. And you know what she said? Well, can't we just sprinkle some on top? I feel like that's what we try to do with the work around equity. We know our society got baked without equity in it. We, the people, didn't include everybody, right? And we just keep trying to sprinkle the sugar on top. And I will tell you, I did everything I could with that cake. We cut it up. I mixed it with ice cream. We tried to make it an ice cream cake. I put some chocolate syrup, and it just was awful. It just tasted like bleh with all the stuff I had put on top, right? And so that's really the question. I don't have the answer, but it's the question that we should be asking. Think systems, structures, go back to that fence. Think about what is already set up and how was it set up and what didn't get baked in, and am I trying to sprinkle something on top? I'm gonna slide through this. This is a hashtag that I founded called Mandate Equity. And I say if equity really matters, it should be laws. Mandates would give us, researchers, the pull to figure it out and partner. Federal mandates will push states to figure it out. I'm gonna give you 2 clinical examples and then I will stop. I do believe, and I'm gonna give you an example of how you can inspire a community of practice. But you have to attach what you want to what the folks in power want. And I'll tell you that. And where I say, where there is goodwill, there is a legislative way. That's what mandate equity is all about. And again, this was COVID. So look, there's Dr. Deb in her green jacket and my red heels. I used to always wear red heels. 2 of my community partners, and that's President Biden. And we say we need legislative pull for all the community push. If we're gonna push a boulder uphill, we need our legislators to be backing us with laws and policies and mandates to help pull that up. All right, so, I'm gonna skip through that. All right, I'm gonna just give you these 2 examples. So the first one, we worked with Michigan Medicaid. Go back to, I said one of the things we uncovered was we saw this huge disparity in who was getting started on medication-assisted treatment in the ED. And in some instances, it was as much as a 15-fold difference, just by race. There were some other variables, right? Like insurance status and some other things, but race was really the biggie. So Michigan Medicaid for their, and so this is what was also really interesting. When you talk about Medicaid, now you're dealing with a population that in theory should be more homogeneous, right? They should be more alike than they are not. It takes out some of the, well, it could be that being white or being male or having private insurance is, really linked to economics, right? Because when we did talk to providers, a lot of people said, well, some of the reason why is we're like, this person isn't going to be able to sustain this. They were unstably housed. They were this, they were that. It's not my fault that that's disproportionately overrepresented in this group versus that group, like that, right? So now we're with a Medicaid population. So those factors should be pretty similar across the groups. Short version is the way their enhanced dish payments work. It used to be by provider, but Michigan has these regions. So we said to individual providers initially, okay, we will tolerate no more than a whatever fold difference. People went up in arms. So they did a phased approach and said, okay, you have this amount of time, this next year to, cut your difference from 15 to 10. The next year you got to be to 5, and we will never tolerate anything more than 5% difference. And people said, okay, fine. Some providers were like, well, this isn't our problem. When we look at our data, we don't have this problem. Our difference isn't that big, like that. But they have a hospital or another provider in their region that is having a major problem. And you know what they said? Not my problem. So we made it their problem. And we made the enhanced payments a regional model. So now if you got it figured out and you won't help the clinic down there figure it out, well, everybody's going to suffer. And we inspired communities of practice. And 3 years later, we hit the target, and that disparity no longer exists. That's how you do it. You attach what you want to what they want, and they want those enhanced dish payments, so they figured it out. And the people who were already doing well now had to be good partners and help others figure it out. Last thing, all right, I've run out of time. I'm gonna give you just another quick example again about ways to think about it. So I'm talking to a colleague, and the colleague is telling me about this patient. And she says, it's just really unfortunate because this woman went for a colonoscopy. You know, she's had them multiple times. If there's no way that she should have been screened negative, right? There's just no way. So by the time she gets diagnosed, it's progressed, whatever. They're, you know, expecting a bad outcome. And I was like, well, why is that the case? And she said, a big part of it is that African Americans are just disproportionately like screened negative when in fact they've got some, you know, polyps or indications or like that. And I'm like, why? She was like, I don't really know. So they changed the age to 45 when you get your colonoscopy. So I was like, I'm going to go get one and I'll figure out why. So I went and got a colonoscopy, which the only thing about it that was cool was the propofol. And it was so fast, I barely remember it. And what I realized is I could look at my record. I said, I want to see everything because I'm trying to figure out how will we know? And then I worked with our community hospital, Hurley Hospital. And I said, let me just look at the data. De-identified, but I do need, you know, race, insurance status, you know, all the sort of things that I think might be culprits that would help me understand. And I was like, it doesn't really make sense. And they did. They had a problem. They had this disproportionately high false negatives overrepresented in African Americans. And I was like, it doesn't make sense. So I'm trying to reflect on my own experience, which of course I don't remember it. I got the propofol and then the next thing I know, I'm waking up. Then I found a variable. And there was one thing, and it was one of my trainees, Adam Milam, who's an anesthesiologist. And I said, it has to be, he's the one who we did the even in death paper. And I said, it has to be that they're just doing not as good a job on African Americans. Because there's another variable, I'm not that kind of doctor, that basically says how good they did the prep work. And that did explain some of the variance, but it didn't come close to explaining what this variable did. And he said, well, if you want to know, I can't tell you about the quality, but as an anesthesiologist, I can tell you that the start and the end time of the anesthesia is logged. 12 minutes less African Americans were getting. And evidently, everything about the colonoscopy is just poking around and looking and like that. So they were more likely to get the quick and dirty version. And that's something you can intervene on, right? And you can monitor it. You can tell people, we see, and you can identify if there are certain people who are doing it faster or like, it just opened up this whole entire world around that. So I've been sharing that story with others and I've been working with other colleagues. I'm giving you like the epi sort of version, but don't you want a cool epi health disparities researcher as a friend? This is why I think, because I would have never been able to figure this out on my own. Me going to get a colonoscopy was good for my health. It made no difference for me in understanding like that, but it was the partnership with a clinician friend. I see the Sandman's over here. He's about to pull me off stage. So I'm going to end here. And yep. I'm going to skip that too. And I'm going to leave this final word to trainees and early career professionals, which is to stay on purpose. How you'll know, there's what the world wants and needs. And if you can find something that the world wants and needs that you also love, and I don't mean like kind of are interested in, but something you love. And love can grow, right? But it's really rough, I think, to do something long-term that you don't love, right? Something that you can get paid for and you're actually good at it. When all those things come together, I think you will find your purpose. And it's not a destination. It might change. The things that you love to do might change over time. I used to love being an administrative leader and all of that. And now I want to do other stuff. It's so weird. I thought I was like, oh, I'm just going to be on this path. And now I'm like, no, I want to make patents and actually build the solutions for this stuff now. And I don't even have to do it. I just got to fuel the ideas and work with a great little tech firm. So you're not stuck. You're the creator and inventor of that for yourself. So be encouraged. I hope this was good for you guys. And there's lots of other bonus slides and other things, but I'm going to stop so we actually have time to talk. And I'm going to leave it on this slide. Thank you.